unaccustomed I am to controversy, my first statement and disclosure will be, in my opinion, microfracture is probably one of the worst things ever to happen to cartilage repair, and I'll try and explain that a little bit as we go. But essentially the problem is that microfracture is scientifically flawed. So ROCKSTAR has said that the properties of clot induced by microfracture are not conducive to healing back to normal hyaline cartilage, in a large part due to the limited scaffolding on which marrow-derived stem cells can attach. And essentially the problem is that the concentration of MSCs within bone marrow is incredibly low, and if it's approximately 0.01% of all the cells that you get out of bone marrow is actually an MSC. So the regenerative potential from a microfracture is very low. So clot formation with marrow elements is remodeled and organized to fibrocartilage, and that's primarily comprised of type 1. So as a consequence, this is histologically flawed. So it lacks many of the intrinsic factors, biomechanical and as well as mechanical, of normal hyaline cartilage. It's more stiff compared to articular hyaline cartilage, and it doesn't have the same shock absorbency and force distribution capabilities as normal hyaline cartilage. And if you biopsy it, Carl looked at biopsies in 5 patients, an average at 8 months, and he looked at polarized light microscopy, and it revealed that collagen fibrils were disorganized. They were in a vertical pattern relative to the joint surface. The fibrocartilage was cellular rich, where hyaline cartilage is not, and the proteoglycan contact was pretty poor and was less than the surrounding cartilage. And then Knudsen, in his sort of quite famous paper, when he compared microfracture to ACI, he looked at the results, and the predominant repair in microfracture was fibrocartilage, although 20% of the biopsies were classed as inadequate and showed no repair tissue at all and were predominantly bone. 51% of the defects were filled with fibrous tissue, so it's not even fibrocartilage, it's fibrous tissue. And we all know that fibrous repair or fibrocartilage has poor durability as a consequence. Not only does microfracture result in an inferior histological result of the cartilage itself, the main issue in microfracture is the alteration in the subchondral bone. It's essentially doomed to fail. So if you look at this is a microfracture hole created by a drill, and this is a microfracture hole created by an awl. And if you look at it, the awl results in significant bone compaction. So it's much denser around the awl versus the drill. And similarly, if you look at in the sort of longitudinal plane, similarly there's the drill, this is the awl. You can see the bone density at either side is much more significant. It results in bone compaction. As a result, it blocks the vascular channels. So it reduces actually the amount of clot that enters the hole. And if you examine histologically the cells around this area, if you use an awl, you get approximately 20% cell death of the osteocytes, as opposed to a drill, it's around about 9.7%. So because of this issue, you can't actually get the marrow into your clot. So that's why histologically it's even more inferior than best chance. And if you look at Mithofer and his study of 84 patients undergoing microfracture, an average of 22 months, he noticed a subchondral overgrowth occurred in 62% of patients. So you've created a fracture within the bone, and the bone tries to heal itself. You get callus formation, and then you get these intralesional osteophytes, as you can see here. So 93% of patients who failed microfracture procedure were found to have this intralesional osteophyte, and the presence of an overgrowth or osteophyte was associated with an increased failure rate. And this is probably the main mechanism by which microfracture heals. It's also limited to certain populations. It's not universal as a treatment. So if you look at individuals 40 years of age, older and younger, in this study, 85% of patients following microfracture of the knee patients aged 40 years or younger had significantly better results. So at 18 to 36 months after microfracture, the ICRS score deteriorated significantly in those over the age of 40, where it tended to plateau in those under 40. And the MRI results were much better than those under 40 years of age as well. So it's very age dependent. And then if you look at athletes, we all hear that microfracture is the gold standard for athletes, but actually if you critically look at the literature, it doesn't do that well. So in this prospective randomized controlled trial of 30 patients, all of which were athletes randomized to either oats or microfracture, there were 4 failures in the oats and 11 failures in the microfracture at an average of 10 years. There was statistically significant difference in ICRS and Tegner scores favouring oats as opposed to microfracture, and 25% of the oat patients versus 48% of the microfracture patients were found to have evidence of Callaghan-Lawrence grade 1 osteoarthritis at 10 years. And similarly, in this study as well, where they looked at the same scenario, but a complete meta-analysis of 6 studies, totaling 249 patients with an average of 67 months follow-up, oats had a higher activity level as measured by Tegner score compared to microfracture. There was a lower risk of failure with oats with lesions less than 3 centimeters, which would be expected, and no difference as between the 2 treatment groups for less than 3 centimeters, but activity levels were much higher in the oats group. And if you look specifically at activity, so a total of 1,375 patients who underwent microfracture, ACI and oats. So ACI and oats demonstrate significant advantages over microfracture with respect to majority of patient-reported outcomes. ACI was found to result in superior Tegner scores at 1 year and IKDC scores at 2 years. Oats was found to have superior Lysum scores at 1 year and MARC scores at 2 years. Microfracture, the only positive thing you can say about microfracture compared to the other 2 treatments, that it had positive or better Lysum scores at 1 year when compared to ACI, but then they deteriorated by 2 years, so it was no longer beneficial. And you would expect that based on the treatment that you received. So ACI and oats were more advantageous than microfracture and overall improving activity levels. And only small lesions are suitable with microfracture. So Mithofer, again, he showed that microfracture should only be used for lesions less than 2 square centimeters. And that was very predictive of return to sport. If you had a lesion greater than 2 centimeters, your return to play was much reduced. And a chondral defect in the non-weight bearing area of the knee, as well as shorter duration of symptoms of less than 12 months, had a better outcome. Out of 2,549 patients, 34% underwent microfracture. Following the microfracture, there was a 58% return to play rate at an average of 9.1 months following surgery. But if you look at the oats and ACI group, the return to play, and they even compared allograft in this group as well, but so in terms of allograft, oats and ACI, the return to play were 88, 93 and 82%, so much better than the 58% following microfracture. So microfracture was associated with the lowest return to play rate, with the next lowest being ACI. If you look at surgical technique with microfracture, it's generally done very badly. And in this study, they took 4 very experienced, fellowship-trained arthroscopy surgeons, and they just tried to get them to state pre-surgically the spacings of the hole and the depth, and they were trying to get them to judge this. And basically, they found that all 4 surgeons misjudged the depth and the spacings of your microfracture hole, and they basically found that the holes generally tended to be too deep and they tended to be too close together. And when you do that, what happens is that you get this phenomena where the holes tend to merge, you get this sort of coalition, and then you get more shearing as well when it's too close together, and as a consequence you get more compaction and more sort of AVN and less clot formation. If you look at histological analysis of surgeons undergoing or undertaking a microfracture, so you do it in a cadaver, you take it to the lab, examine your results. The ability of a surgeon to create vertical walls is not very good, and similarly the ability of a surgeon to remove calcified cartilage layer is pretty poor as well. And if you don't remove the calcified cartilage layer, the fibrocartilage will not stick to the bone and generate in a poor result. And then this is the sort of argument that you get where, no way, in that you don't burn any bridges with microfracture, so why don't we just do it? Yes. But you do burn bridges with microfracture. It has a detrimental effect massively on any future treatment. And Tom Minus's paper, this is the sort of seminal paper in this area, overall failure in the microfracture group is 20%. And up to a third of patients treated with microfracture demonstrated thickening of the subchondral bone, osseous overgrowth, intralesional osteophyte or subchondral cysts. So it's a huge failure, a huge implication for future cartilage treatment. And even total knee replacement. So this paper was out this year from orthopedics. They took 20 total knee replacements performed at a single tertiary referral centre, and they looked at 21 patients who had previous microfracture. They reviewed these based on 42 patients who had no microfracture, and what they found that the knee severity score, both subjective and functional outcome scores, were worse in those patients that had previous microfracture, and the failure rate at 5 years was 4.8% in the microfracture group versus 2.4 in the control group. Admittedly, low numbers, but I think it sort of makes sense. If you damage the subchondral bone, that is going to affect your outcomes. And this is probably the worst thing about microfracture. It's free, and because it's free, there's no financial implication, and I think it sort of disconnects the head to the rest of the body, really. And the problem is there's great temptation to just do it for incidental lesions, and often the other factors have not been considered. So you find an incidental lesion, you have this free microfracture set just there, sitting there, going, use me. And you haven't assessed the alignment, you haven't assessed the other factors, you may well have just carried out a meniscectomy, you've not really thought how much I've removed, and as a consequence, you do a microfracture, and this has implications, because if you do it badly in the wrong patient, it's going to fail. So in conclusion, microfracture is scientifically, histologically and functionally flawed. It's often done poorly. It's often done in incidental lesions without thorough planning. It does burn bridges and compromises future repair after the inevitable failure. And so we're going to about it here, we go, right, okay, but if we drill smaller holes, it'll do less damage. And admittedly, if you use a drill, you can achieve some efficient results, and it can all work brilliantly. But ultimately, if you've not really fully prepared, so the old 5 Ps of piss poor performance. Oh, sorry. If you're, sorry. Here he goes. Oh, sorry. This fella, he's just found an incidental cartilage lesion. He's decided to give a microfracture a go. He's got his drill out, and here he goes. And then, there are long-lasting implications of doing a bad surgery. Okay, cheers.
Thank you, Martyn. Right. Fantastic. Right.